You are listening to the Movement Therapy Podcast.
Hello, welcome back. Thank you for joining us again, episode 2 on the Movement Therapy Podcast, or 3.
Who knows?
Could be one of them. Review from previous episodes, or last week's episode, having an overall look at what back pain was, and I guess just understanding that it's a massive issue. We discussed the funding, obviously, a bit of a drier topic, but eventually where the funding is going and where we needed it to be. So essentially we want it and need it in the private sector to be able to improve pay for staff, subsidise costs for the public, improve equipment, improve spaces, grow clinics, etc., etc. And we discussed how we actually diagnose someone with back pain, what's sort of the process we go into that.
Yep.
So we talked about the structural and functional diagnosis. And we went through some of the basic anatomy of the lower spine.
We did.
Which was gripping stuff. And also some scans. We're going to talk about that today as well.
Woohoo.
So
what are we talking about today, Ethan?
on to today's episode, we're going to talk about the world of acute low back pain. So what I mean by acute back pain is essentially pain that doesn't last very long or hasn't lasted very long.
Cool.
So today we're going to talk about what that is, what it means, some of the conditions that go along with that, how to manage it, and when to present to hospital. This is going to be an interesting topic. Or when to go for further medical interventions.
Yeah.
And what sort of treatment looks like from our point of view, from the clinic.
Let's do it.
Let's get stuck in. So there are so many definitions of acute back pain. I don't think there's one that actually defines acute pain, but essentially I define it as recent new pain in the lower back, so anything under the ribs and above the pelvis that may be about sort of 0 to 12 weeks old. So sort of that 3-month mark.
Yeah.
So anything in that range, we kind of classify it as acute pain.
Okay.
So we can further sort of subdivide this into 3 categories. So you've got subacute.
Yep.
And this sort of is just the outside of the acute phase. So say you've had pain for about 3.5 months, 4 months. It's not the 6-month mark of the chronic pain saga, but it's just falling outside the 12-month mark of the acute pain. So that's we would define as subacute pain. Then we've got the actual just acute pain, which is just new pain, 12 weeks old. Then we've got a third category that's called the acute on chronic pain. So this defines pain that has occurred because of a previous known issue. So, but essentially you were pain-free.
Okay.
So let's say you were treated for some back pain or a shoulder pain or a mid-back, upper back, neck pain, for example, 2 years ago.
Yeah.
You became pain-free after that.
Cool.
You lived 2 years pain-free and then suddenly you got back pain again. And if I assess it and then attribute this back pain to that previous issue, we call that acute on chronic pain. So you've had an acute flare-up of a chronic problem.
Yeah.
So this is why we need to really diagnose the chronic injury and the first problem. So a lot of the time in the history, we'll actually go back through your past to try and find the first injury.
Yeah.
So you might be like, oh, why does he care about, a fracture I had when I was 16? It's all healed and it's fine. But as soon as you have something that changes your anatomy, so talking fractures, surgeries, major or minor, even ligament rolls, ligament strains, these sort of things, that can have a massive impact on back stability, spinal stability, pelvic stability down the track. So anyway, we'll talk about that in the chronic low back pain podcast. We don't have time for that today because we've got too much to get into.
So much stuff to chit chat about.
So that's acute pain. I sort of say when you're in acute pain, what's the steps we need to do? So firstly, we need to decide when to actually present to hospital.
Yeah.
So this is an important one. I don't know if you remember last week, Zoe, we had a stat that said how many people presented to emergency.
Yes.
It was one of the top 5 causes people presented to the emergency department was low back pain.
Yeah.
And it was the second highest reason people presented to the GP. So huge numbers there. And for now, what I really want to be able to do is kind of clear out the emergency departments of back pain and the GP waiting rooms. I don't want clients to wait around or patients to wait around in ED for 5 hours just for some pain relief. I want them to be able to present to a clinic straight away.
Yeah.
So private clinic, physio, osteo, chiro, a hands-on therapist straight away. That way we can assess and we can progress our treatment plan from there straight away.
Perfect.
So let's go into some stats and some research, which I know is your favourite part.
Yep.
The APA, so the Australian Physiotherapy Association, was quoting the Australian Commission on Safety and Quality in Healthcare, which is a reference I'll put in the show notes as well. And that states that about 1% of all clients presenting with acute low back pain have a serious pathology.
Oh,
So that's not a lot. That's
yeah.
1%. So, and I use serious in quotations because, and we'll sort of talk about what constitutes a serious pathology in a minute. But
Okay.
it's not a lot. It's not a lot of.
That is, not a
It's
lot.
not a lot. So if you have 100 clients presenting to ED, one of those patients is going to need that service.
Yeah.
It's tricky because it's such a case by case dependent
Yeah.
scenario. It's not a rule in any state. So I don't want you to sort of be thinking, I don't need to go to hospital or I shouldn't need to go to hospital. If you do need to go to hospital or feel like you do, please go.
Do it. Yeah.
Just do it.
Just do it. Don't listen to us.
Exactly. What I want to try and provide here is a bit of education on where you might not need to go to hospital. And if we can provide that, then we'll be able to sort of reduce the burden on the emergency department and
Perfect.
keep those open for the trauma cases, these things that are unavoidable, that need hospital treatment. So let's just take a little tangent onto scanning because this comes under I'm really passionate about scanning.
Yeah, we're going to have to do a whole...
We're going to go back into
whole
scans
thing.
because someone might not have listened to
Scan.
the previous episode
May not have.
and they don't know about scans. So let's talk about acute scans. Now, if you have an acute pain, most of the time, and this is just anecdotal evidence from clients that I've treated in the past, but most of the time I get told, I need to go and get a scan. It's bad enough for me to get a scan. So this is the mindset that I'm hearing a lot in the clinic is that when something is bad enough, the next stage is going to get an MRI. So again, we can use the picture of a door analogy.
Yeah.
Remember that. So if
I
you
do.
have a picture of a door, you can't tell whether it opens or not. It's just a picture. Could be looking great, but it could be blocked from the outside. So it might not open.
No.
But what you'll find with back pain scan, let's say an MRI, and let's say if you're over, say the age of 40,
Okay.
you'll probably find some disc bulges. You'll probably find some arthritis.
But you know what you won't find? A slipped disc.
Oh, that's very good.
So you have a scan, you're over 40, there's going to be some stuff in there.
There's going to be some changes.
But
yeah.
It isn't necessarily why you've got back pain.
Well, we can't ever prove that it is or it isn't.
It's
so
just
this is the
kind
problem.
of there.
It's just there. So this is a really important one because I want to be able to prevent fear.
Yeah.
But you can't unlearn something you learnt on a scan.
No.
So if you see a scan and it says, severe disc bulge L3, L4, you have that forever.
Yeah.
You will never be able to unlearn that. Whether or not that disc bulge reabsorbs and disappears, which it can do, in your head, you will still think that you have a disc bulge.
Oh, yeah, for sure.
So this is the problem. You can't unlearn what you see. So you have to take that scan with a big grain of salt. And this is where a primary healthcare, such as a clinician in a private clinic, will be able to go through the scan and talk you through it and talk about the things we need to change and the things that are important and the things that are really not important and just incidental findings.
Yeah, I think a blessing and a curse is being able to see your scan before a physio or whoever can.
Yep.
I'm chronic for it. I'll look at my scan straight away and I'll go, yep.
There'll be some big words.
Done.
You'll be...
I'm done.
Yeah.
And then I go in and see you and it's fine.
Yeah, so it is a blessing and a curse. And look, sometimes we need it. Sometimes we need to know. And I'll talk about that in a second. But most of the time, I think it creates fear. I see it in the clinic a lot. People without pain get a scan, or even people presenting with a little bit of pain get a scan and then their pain worsens. That's a really common one. Not because of any mechanical reason, but the fact that they've now learned they have a pathology.
So the scan, long story short, isn't the be-all, end-all.
No, exactly. But it's important if it's needed.
If it's necessary, yeah.
So this is where we talk about serious pathology.
Serious.
Yeah, again, we're talking about 1% of cases.
Yeah.
So it's a really, really, really small number. I can't emphasize that enough, but it does still exist.
So what would you classify as a serious pathology?
So the main one we're going to talk about is called cauda equina compression or cauda equina syndrome.
Right.
And that's actually Latin for the horse's tail.
Oh.
Yeah.
Nice.
So we'll go into that in a little bit more detail. But other things we're looking for or clearing in our tests are spinal infections.
Yep.
Spinal fractures. Any
Not-
neurological defects.
Not fun things.
Very, very bad things.
Yeah.
So neurological defects, so spinal cord damage, Also sort of peripheral nerve damage. If we sort of suspect nerve tears or nerve ruptures, these are not nice things. Or significant spinal cord compressions.
Okay.
You notice I use the word significant and not minor, because you can have a minor cord compression, which might still be manageable without sort of need for surgical intervention or any other medical intervention. And the obvious sort of tumours, growths, cancers, these are things we need to obviously scan for to check.
Yeah.
Now, we're screening these in the clinic. So we're asking very specific questions on these pathologies. And it's a way everyone who comes in with back pain, we are screening for these things. And I guess the important thing is, if you present to one of us in the clinic, we will make the decision if you need to go to hospital or not.
Yes.
And if you do, we're getting straight onto the ambulance. And the benefit of the clinic is that it's right around the corner from the hospital.
It is.
So
it's very
probably
convenient.
just take you ourselves.
Just drop you off.
So we know the signs. Obviously, we know the questions to ask. And that's the important thing as well, is that we can screen to make sure that you're in the right place.
Yeah.
If all of these tests are negative, cool, we can treat. If not, you're in the hospital. And you're getting attended to in the medical profession.
We'll chat soon.
Good luck, and hopefully we will chat soon. Now, cauda equina.
Yes.
Big one. So the cauda equina is a bunch of nerves at the base of your spine. So if you look at a nerve picture in a textbook, or you Google one, or even look at an MRI, you'll see that the nerve goes from the spinal cord into a little, like the jellyfish legs, essentially.
Yeah.
So literally picture a horse's tail. So from where it's attached into the body, and then it comes out, these are the nerves.
Hairs.
And it's the hairs. It's all the hairs. So it's literally Latin for horse's tail.
Okay.
And these are all the nerves controlling everything south of the pelvis.
Yeah, so they branch off and then go down into the legs.
Exactly.
Business.
Exactly. So including the pelvis, including bladder and bowel, legs, knees, feet, everything
All of that.
south of the pelvis is innervated by
Horsetail.
the horse's tail. So if you decide to compress the horse's tail, and this is a significant compression. So we talk about disc bulges. You need a massive disc bulge to irritate the cauda equina.
Yeah.
I personally have never seen it in clinic, and I've been treating for 8 years, just under 8 years.
Okay.
I have spoken to a few people that have suspected it, but I've
Yet
to come across it in clinic. So again, very rare.
Thankfully, because it doesn't sound fun.
It's really, really not fun. Now, it is a medical emergency because those nerves obviously innervating everything to do with the lower limb.
Yeah.
The main question for cauda equina we're asking is bladder and bowel. So are there any changes to bladder and bowel? So frequency, type, pain, any incontinence in the last sort of hour, 2 hours, 24 hours.
Okay.
It's going to be a quick onset.
Yeah.
You're going to feel it. We also sort of call the term saddle paresthesia. So think of the area of the body that's in contact when you sit on a bike saddle.
I was going to say, there's a lot of horsey stuff.
A lot of horse stuff, right? Yeah.
Yeah.
So it's more sort of localized to the bike rather than a horse saddle, because that's kind of everywhere.
Like your legs and everything as well, yeah.
But think of a bike saddle. Everywhere that's in contact with that bike saddle, if that starts to go numb or changing sensation, if it's very sensitive,
not great.
Got a problem.
Yeah.
So that's a massive one. And the obvious ones are if you lose massive amounts of weakness in both of your legs. The important part is both your legs. If you do a cauda equina compression, you will lose function in both your legs.
Not just one?
A majority of the time. Yeah.
Okay, yeah.
Yeah. So you'll either have severe pain in both legs, traveling down the legs. You'll also get severe weakness in both those legs. You may get some sort of sciatica type pain or sciatic type pain, so that back of the leg pain as well, more prominently than the front, but it's inconsistent. You might get. So they're the sort of symptoms to look out for. Now, if you have all of these, don't bother coming to the clinic. That's 000 straight to the hospital.
Yeah.
If you sort of have one of those and it's not that bad and you sort of are wondering, cool, jump on the phone to your local physio clinic and either chat to them or book in for an appointment, and we can assess and make sure you're in the right place, or send you off to hospital if you need to. But that's a big one. So cauda equina. Now, usually it's a surgical correction to clear up whatever's blocking it or whatever's injuring it, and most of the time it's going to be a disc protrusion or some kind of insult to the nerves there. So that's a surgical one.
A rare one.
Very rare, but not impossible.
Yeah.
So let's get on to sort of advice for low back pain and what you should do if you come across some acute back pain. Now,
I'm tuning in.
Yeah, this is one for you, Zoe.
This is for me. So my back's sore right now.
Yeah.
Let's go.
So what we need to understand, if you sort of have an acute back pain or you think you have an acute back pain, we need to understand if it's able to be explained.
Yeah.
So if you can sort of go back and, oh yeah, I fell off a ladder and now I've got a sore back. Cool. Okay. It's explainable. It's not a weird sort of freak, I've woken up, now I can't move kind of a thing.
Yes.
So if that's the case, if you sort of hit the I wake up and I can't move, that's going down the more, cool, can I feel my legs? Do they hurt? You know, how's my bladder and bowel? How's my saddle? Am I losing feeling in your legs? That sort of stuff. They're the questions you need to be asking yourself. Again, hopefully without any panic. It's hard when you're in that much pain.
Yeah.
You know, falls, things like car accidents, these things are explained. So if you have an explained acute back pain, much more likely going to be a clinic referral straight in and just getting assessed. And
I guess the explanation as well isn't just always your obvious like car crash, falling off a ladder.
Yep.
It can just be, you know, I ran. I did a big run yesterday.
Yeah, absolutely.
Do I usually do big runs? Absolutely not.
Yep.
That would make sense as to why I'm sore.
Yep. And don't think because you're strong, you can avoid this as well. I've had, you know, big tradies that are on the tools all day suddenly lift, you know, a pillow from the floor.
Yeah.
Or lift their 5-kilo child and suddenly get this back pain straight away.
Yeah. So I guess, there's commonly, I think what we discussed last time as well, like with your science homework, there's a reason for things. The body doesn't always just make it out of nowhere.
Exactly. So what we need to figure out is what's the cause. Now, if you do go for a big run or you do something that you don't think or you've done before and it's like, why is this causing back pain? That's when we go backwards and we're sort of going, there's something else here. Your back shouldn't spasm. It shouldn't create this massive sharp pinch in your vertebrae. Yeah. So we're sort of using words like that shouldn't happen. If that's the case, we're looking back in your history and we're going, there's going to be some other cause here to sort of fill out this picture of back pain for us. So that's going to be number one. Is it explainable? Now, then we talk about those sort of signs and symptoms, whether you need to go to hospital or not, and then it's an ambulance situation. But if it's not, if you sort of clear the list and you go, well, I don't feel anything down in my legs or anything, my bladder and bowel's fine, you know, I passed the test, then what's the next thing?
Get you on the phone.
Get me on the phone, 100%.
Call up Ethan.
Call up the clinic, absolutely. Get an appointment. But before that, potentially, I want you, well, if you are in a safe environment, so, you know, in your house, in your bed, even sitting at work, you know, etc. If you're in a safe environment and you can just stop for a second, just stop what you're doing and just focus on either where you are and just breathe. Take a couple of seconds, a couple of minutes just to breathe.
Yeah.
To stop the panic.
Yeah.
Because that's the main thing. Your body's going to start panicking. As soon as there's pain, there's fear.
Yes.
So we need to get rid of this fear and panic from the body. So we just need to be able to take a few breaths.
Yeah.
It might take a few minutes. The most important thing is not to move quickly or jerkily and just move smoothly and slowly. Give your brain time to just settle down.
Settle down, rational thinking.
Exactly. Because as soon as you've got panic and fear in there, you're not going to be thinking straight.
No.
You're going to be thinking worst case scenario, and that's not a good place for us to rationally be able to think. So it's just about taking that few seconds, few minutes just to breathe, and then you can start moving. Slow, very slow, deliberate, smooth movements.
Mm-hmm.
Start with your limbs, legs, arms, neck, that sort of thing.
Yeah.
And then see if you can stand up and go. Now, I'm not saying the pain's going to go away, but the brain's going to be much happier with you. And so it's going to take the threat away from that situation.
Good.
Which is going to reduce your pain. The next thing to do is get an appointment with your nearest physio, chiro, osteo, hands-on therapist for proper assessment and treatment.
Call up Ethan. Actually, call up Zoe.
You could call up Zoe.
Call up Zoe at the desk.
Call up Zoe at the desk, and then she'll put you through to Ethan. Now, again, we're looking for an assessment, so as soon as you can, don't necessarily wait, you know, until it gets better. We get a lot of clients through the clinic that sit on these kind of pains. If they do sort of take the threat away, do a couple of breaths and go, oh yeah, it's not too bad. Wait a week, gets worse. doesn't do anything about it, waits 2 weeks. Suddenly it's a month later and it hasn't gone away, then they come in.
Yep.
That's a little bit harder to manage.
Yeah.
Because your body's
sorry.
starting to make changes. As soon as you have pain, you change the way you move.
Yep. Don't look at me while you're talking about this.
I'm not saying any names.
Just as soon as you saw, go in.
As soon as you saw. Now, even if it is a one-off acute back pain that is just because you did a movement that you're not quite used to and your brain's a little bit scared about it, great.
Great.
Come in for an assessment. We'll screen it. We'll make sure it's nothing serious. Potentially do some treatment if you need it. And then that might be it.
Best case scenario.
Best case scenario. We only want you in the clinic as long as you need to be there.
Best case scenario in the nicest way possible, never see you again.
Absolutely. And even better case scenario is that we actually find some things that we can fix.
Yeah.
So that you don't have this again.
Yeah.
Because there's nothing worse than especially a young person coming in and saying, oh, I've got back pain and I've had it for, every 6 months since I was 10. And I'm seeing that really, I actually had someone yesterday come in with it. She was early 20s.
Yeah.
And has had back pain on and off since she can remember.
Yeah.
And so has normalized it.
Yeah.
And it's on and off, but has these severe acute episodes. That is what we would call an acute on chronic back
Acute on
pain.
chronic, that's the one.
Now, her diagnosis is not back pain or non-specific low back pain.
Yeah.
We have to go in and find actual issues. So we found a couple of things, but yeah, we need a couple more assessments to actually make sure we nail this diagnosis. And that's the point. If you've got an acute on chronic pain, we need to nail that diagnosis first.
Yeah.
And make sure we've actually treating the right thing.
Yeah.
Step number one, obviously, we've got to get rid of the pain.
Yeah.
Because like I said, as soon as you're in pain, you change the way you move.
Yeah.
That's I don't think I'm emphasizing that point enough. There's a reason we're called movement therapy.
Yes.
Is because movement is so important and the way you move is important more so.
Well, yeah. I mean, yeah, if you've got a sore foot or whatever, you're not going to want to walk on the toe that you're hurting. You're going to
Ever
walk on
stubbed
the
your
outs.
foot?
Yes.
The little toe?
All the time.
It's the worst.
Worst. And
Worst pain.
but you either you change the way you move. You're either
Exactly.
hopping or you're limping and
Yep.
stuff like that, or that you change the way that you throw, catch,
Yep.
pick things up.
If any tennis
Well-
player out there has had a sore shoulder, they're going to change the way they serve.
Yeah.
Now, changing the way they serve means that you're going to use other things.
Yeah.
So you're going to change not just the shoulder, but you're going to change the scapula, the shoulder blade, the lower back to get the angle, the hip, the foot, the ankle.
Yeah.
There's so many things. Every joint is connected to every other joint,
Unfortunately, which is what we talked about last
which is what we
week.
talked about last week.
We're not
So
Lego people.
no, which would be amazing, and it would make my job very, very easy. So this is the sort of the main thing I want you to think about is that we need to assess and treat.
Yeah.
And hopefully discharge. Okay. So that moves on to how we actually treat acute low back pain.
Yeah.
So if you do find yourself coming into the clinic and you've had back pain for a few days
Welcome.
and you sound silly, if you think, oh, I shouldn't really be here. I feel like I'm in the wrong place. It's starting to get a little bit better and I don't know why I'm here. It's the best place for you to be.
Absolutely.
And usually what we need to do, the first sort of step, like I said before, is get rid of the pain.
Yeah.
So we do this with one technique or with a couple of techniques, but one of the techniques is actually reducing the threat to the central nervous system.
Okay. How do we do this?
So it's also called down regulation of the central nervous system. And essentially we just need to calm the nerves signals down.
Right.
And we do that just by slowing things down, getting you on the bed.
Yep.
Usually breathing is a massive part of this. Now, if you've ever been to our clinic, you will have been taught how to breathe, I'm sure.
Oh, yeah. Yes.
I don't think a person goes through, especially my diary, that I don't
No.
teach how to breathe or how to maximize their breath
It's a weekly occurrence.
or in some way prove that breath is super important. So we will get into this more in our chronic pain podcast, but the breathing is massively important just purely for our down regulation of the central nervous system.
Yep.
So we use exhalation to reduce heart rates and
Yep.
to actually reduce the nervous system signal. There's a lot of science into that. I'm not going to go into that specifically, but just to reduce anxiety around the pain as well,
Just by chilling out.
just by literally chilling out. So we try and, that's sort of number one, breathing and returning your brain to a state of happiness or just contentedness. Then the next step is we've got to return movement to where it was lost.
Yeah.
So if you, say, have a muscle spasm in your mid-back because of that low back pain, you're going to lose movement in your ribs. and thoracic spine, which incidentally is going to make it harder for you to breathe. So what we need to do is return the movement into the thoracic spine without increasing that pain. And that might mean we have to reduce muscle tone or techniques that reduce the muscle spasms in particular areas. There's heaps of techniques, obviously, that we do for that. And it is person to person, case by case. Not everyone's going to respond to the same treatment. So we need to make sure we're individualizing that, obviously.
And it's also not instant fix as well.
Exactly.
Which is unfortunate because I would love an instant fix.
It is a massive shame, unfortunately, but it is unlikely that the pain will 100% be gone. But what we want to be able to do is either improve it, make it more manageable, or just give you a future plan to be able to make sure you reduce the threat and the fear and future sessions if they're needed. But the main thing to note is that we want to assess. We want to assess and correct any underlying deficits. Yeah. So we are finding the cause of this back pain, not just fixing the pain itself. That's important, but we need to find the cause. My analogy here, and I've been using this for a while, I love this one. So you're in a room or a house with a fire alarm, for example. When there's a fire in the house, the fire alarm goes off. Yeah. Okay, this is what we talked about, what we call nociceptive pain. So the fire alarm is detecting the threat or the danger of the fire. So fire goes on, fire alarm goes off, and then, no, that's not right, is it?
On.
Fire occurs, and then the fire alarm goes off. Yeah. Very weird little statement there. Yeah. Because it doesn't go off, it goes on.
It turns on, but it's going off.
Yeah, I don't like it.
We don't need to finish on. This is another episode we talked about words.
Okay, so fire alarm's going off to the fire, okay?
Yes.
This is very important. So we got danger, you got the signal of the fire alarm, that's sending a message to the brain. Brain goes, yep, turn that fire alarm on. Bang, we got pain. I'm going to do something about the fire.
Where the fire? Why the fire?
Exactly. Then we need to figure out how it was lit, why it was lit, etc.
If there was a fire, even.
If there was a fire. Now that comes to a bit more a chronic pain, because eventually the more times you light that fire alarm is not mechanical, it's learning. So it might respond in the same way when you have a tiny fire.
You burn your toast.
That it does when you have a massive fire and you burn down the house. So that's that. We're getting into chronic pain a little bit, but it's a really good point to understand. Is we need to get rid of that signal first. We need to change the signal of the fire hitting the fire alarm. We can't just turn the fire alarm off. Yeah. We have to change the signal of the fire. We've got to put the fire out, stop that pain in itself, and then we need to get your movement back, and then we can start assessing the chronic stuff. Yeah. Cool? All right. As an overview of this back pain, emphasizing that about 1% of all acute back pains require hospitalization. So it's not a lot.
Not a lot.
The important part of that is we want to reduce the fear in people with back pain, acute back pain. Yeah. And educate them as to when to go to hospital if you need to, but to emphasize the importance to present to a physio clinic as soon as you possibly can.
Do you want to know a fun fact?
I would love to know a fun fact.
There is a website that you can use. It's Health Direct. It's a government website, and it has like a symptom checker, and it kind of it doesn't tell you whether or not to go to hospital. Right. But you can have a look at your symptoms, and then it can say whether you should have a chat to one of their registered nurses. Right. And you can give them a bell. And
so you're actually talking to someone, not just Googling symptoms and hoping for the best.
Yeah. And you can give them a bell and they'll run through your symptoms and they'll do kind of a little check and they'll say whether they think you should go to like a walk-in centre or a hospital, or if you can just book in and see someone.
Awesome.
How good's that?
That's good.
Because I'm a Googler. I'm a chronic Googler.
Look, most people are, unfortunately. But that's okay.
This is government Googling.
Yeah. And you actually talk to someone.
That's the good thing.
So that's different.
You can give them a call, run them through, and they'll tell you what's what.
I love that.
So that can either put you in the right direction of the hospital or put you in the right direction of movement therapy website.
Absolutely. And then you come to us and you get a full assessment and diagnosis, and then we're on track for treatment when you can.
Winning.
Perfect. So look, quick overview of acute back pain today, and hopefully that clears up some of the questions you might have. Again, as always, any questions you might have, please reach out to us on any social media platform. We're on Instagram at Movement Therapy Oz. It's AUS. Come follow us on our website as well. Send us an email, pop your head into the clinic, and we'll be able to answer any questions you might have. Until next time, thank you, Zoe.
Thank you, Ethan.